with Kitab Al-Fatihah. Okay, all right. So let me share my slide. Okay, where is it? Share screen. Okay, all right. Let me see if I can make it better. Okay, all right. Okay, so the topic that I'm going to give today is regarding newborn examination, assessment, and care of the newborn. So this is a slide actually prepared by Dr. Mossad. Basically, this is the practical thing that you're going to do today. No, that you're going to do tomorrow. So you've learned this morning about newborn resuscitation. And what we're going to discuss later is how we examine the newborn at different stages of life. And then we will do the practical, inshallah, tomorrow and on Thursday as well. So I think there's 3 groups. 2 groups will be with Dr. Mossad. 1 group will be with Dr. Alwi. And then another 2 groups will be with me on Thursday. So please reconfirm. So the group that has the session with me most likely will do at 8:15 a.m. on Thursday. And then we'll do another session hopefully by 9:15, or there's a small possibility that we do need to reschedule the times. Please get back to me by tomorrow evening. Okay, all right. So again, you do lectures with me. Hopefully, usually it shouldn't be too long. It should be around 1 hour. So there are transition and phases where we actually examine babies. So this newborn examination is the most thorough perinatal examination that must be done by undergraduates, graduate, postgraduate, or any doctor or any staffs that handle newborns actually. So again, when you examine patients, I have always told you before, there are 4 objectives when you clerk any patient. When you get the history, when you get physical examination, there are 4 objectives. When you get history, when you clerk the history, when you do physical examination, when you present the case, there are 4 objectives. Can anyone tell me what are the 4 objectives? Anyone? What are the 4 objectives?
Can I try?
Yes.
So first, to look for diagnosis.
No, to look to get to the provisional diagnosis. Yep. Second.
Second is to rule out the differential diagnosis.
Third.
Third is to rule out the to look for complication of the disease. Fourth is to look for complication of treatment.
So yes, so those are the 4 objectives of case clerking. Those are the 4 objectives of physical examination. Those are the 4 objectives of case presentation. So number 1 is to look for to get to your provisional diagnosis, because you will manage the patient. You will counsel the parents, you will do counseling, you will manage, you will do investigation based on what you think is the provisional diagnosis. So the first objective is to get to your provisional diagnosis. Second objective is to rule out differential diagnosis. And as I have said, so you as fifth year, you need to have at least 5 differential diagnoses that you need to go through. What are the positives and what are the negatives for each differential diagnosis? The third objective is to look for complications of the disease. because all disease, all presentation has its own complication. So you need to look for those complications. And the fourth objective is actually to look for complications of the treatment, because all treatment has its own complication. Well, I have said it before, but for newborn examination, this is probably the only examination where you don't have clear problem. So again, when you clerk patient, when you examine patient, usually there's an issue why the patient comes to you as a medical professional. Kan? It's not just like saya saja datang. Kan? No, there is always something for you to look for. There's something for you to look for. But the thing is, with newborn examination, basically you are doing a normal assessment. You are assessing normality. Previously I talked where there are a problem that we need to identify. So there is an anomaly with the patient from the history, from the physical examination. There is an anomaly that we need to look for and we need to investigate upon. But for newborn examination, so basically we are assessing normality, because again 80% of newborns are normal. Only 20% of them that has something that is abnormal with them. And abnormal with them, it can be transient, it can be temporary, and it can also be permanent. It can also be permanent. Give me 1 second. Give me 1 second. Let me put something. How can I mute? Okay, so again, is the most thorough physical. So basically, you are looking for normality. So 80% are normal. So you are looking for the normal things. So when you do physical examination, it's always good. It's always important. So another thing that I always tell students, when you do physical examination, it's all about showboating. So you are trying to show your skills. Okay. So the first thing we assess when you do physical exam, when you do short cases, the first thing we assess is how you approach the case. Secondly is we assess whether you are safe or not, whether you wash your hand, whether you touch the patient properly, whether you don't cause harm, you don't cause the patient to cry, and so on and so forth. The third thing is we assess whether you have good technique, whether your technique is correct. Third is we assess whether you know what is normal. Then only we assess whether you know what is abnormal. So assessing whether the physical findings are normal is actually a very important part of physical examination. So this is another thing. In newborn examination, basically we are assessing normality. We are assessing whether these certain findings are normal, because certain findings may be normal during few hours of life. For example, for example, the uh, what can I give as an example? Uh, of finding that there during the, okay, for example, cardiac murmur. It's totally normal for cardiac murmur, for you to hear cardiac murmur in the first 5 days of life. Because sometimes PDA, for example, it takes 5 days for it to properly close. Kan? So if you have a premature baby, for example, you don't expect the PDA to close straight away. So finding of a PDA in the first 3 to 5 days of life may not be that significant. And you know, especially because of the because your first lecture yesterday, you discussed about the transition into extrauterine life, isn't it? So you know that the pulmonary pressure is high in utero. In utero, pulmonary blood pressure is high as compared to the systemic. But the moment the umbilicus is cut, the moment the baby is out from the mother's womb, then the pulmonary blood pressure drops significantly. So, but in some babies, there are still some persistent pulmonary hypertension. So, you know, this persistent pulmonary hypertension may cause murmurs and so on and so forth. So sometimes these things may be normal for the first few hours of life, for the first few days of life, but it should disappear at the certain specific time. So how do we assess? When do we assess? There are several phases. The first phase is the first hour of life. Because the first hour of life, there are significant, there are important things for you to assess. Phase 2 is from 1 to 3 hours usually, and phase 3 is from 2 hours and later. And then we also do regular checkups on babies later when the baby is still in our postnatal period. Okay. In delivery room, in the delivery suite, when you attend deliveries, so what are the priorities for you to assess? What are the priorities for you to assess in the first hour of life? So basically, you look for how the baby is adapting to extrauterine life. Is the baby now breathing well? Because respiratory rate, for example, before the baby is born, normal respiratory rate is less than 12 breaths per minute. But the baby cannot sustain just 12 breath per minute. The baby needs to breathe more. And as you should know, normal respiratory rate for newborn babies are up to 60. So that's still okay. Up to 60 breaths per minute, that is still normal. Your respiratory rate 60 may be abnormal, but for newborn babies, 60 is still considered as normal. So whether the baby is adapting well, the PDA, is it close? Is there still any signs of persistent pulmonary hypertension? So how is the baby adapting to extrauterine life? We assess ABGA score. We'll discuss about ABGA score later on. I think you have, I think yesterday we spoke about ABGA score, and this morning I think Dr. Mossad as well mentioned about ABGA score. So we do assess the ABGA score. We look for dysmorphism, any obvious physical dysmorphism. Is there any single palmar crease? Is there any palpebral fissure? Is there any flat nasal bridge, hypertelorism, low set ears, extremely wide fontanelle, alopecia, and so on and so forth. So whether there's any obvious abnormalities, major congenital anomalies, whether there's any sacral agenesis, for example, so whatever the abnormalities. And then is there any birth injury, brachial plexus injury, for example, shoulder dystocia? Is there any, I've seen babies with humeral fracture, I've seen babies with femoral fracture, so a femur fracture as a complication of birth injury. And sometimes clavicular fracture. I think last week we have one baby with clavicular fracture because of shoulder dystocia. So how do they present? Sometimes they present with paucity of movement over one upper limb. So they don't move the affected limb as well as the baby is moving the other limbs as well. So there's paucity of movement of one of the limb. Okay. All right. So whether there's any signs of birth injury or not, we look at the umbilical cord, whether the umbilical cord is still okay. Is there any hematoma? The umbilical cord should have 2 arteries and 1 vein, or whether it's abnormal. We assess the gestational age. So again, gestational age is a very interesting thing that you can actually, from your assessment, you can know what is the gestational age. A few months back, if you remember, we in IIUM, our team from Halimatul Sa'diah Mother's Milk Center, we had a discussion with the Mufti, with the Jawatan Council Fatwa Negeri Pahang. So the issue was there's a fatwa in 2011 from Jawatankuasa Muzakarah Majlis Fatwa Kebangsaan saying that donation of breast milk is harus, al-ibahah, is permitted. But formation of milk bank is not permissible in Malaysia. Even if you look at apa nama Prof Wahbah Azhaili, for example, mentioned that he does not encourage the formation of breast milk bank. But we do think there is an urgent need for a proper Sharia compliant mother's milk bank. So we discussed with them lah. So the discussion was quite lengthy. But one thing I wanted to highlight was the Deputy Mufti, Timbalan Mufti, asked regarding, because there's an issue regarding pregnancy out of wedlock. So maknanya mengandung luar nikah, for example. So they consider as long as the baby is born within 6 months after at least 6 months after marriage, then they say it's considered as so they consider the baby as being born anak-anak dengan nikah lah. Kalau the baby is born after 6 months. But what I told Mufti is that when the baby is born, we can know whether the baby is premature or not, because they said they take 6 months is because 6 months means the baby is premature or not, macam tu. So the thing is, I told them we can know if the baby is born. So for example, if the baby is born after exactly 6 months after marriage, but the baby from our assessment is term baby, so we know that the baby is conceived before the marriage. So but they said from their assessment it's just going to be 6 months, because they said 6 months is the period of viability. Less than 6 months babies don't usually survive. They take 24, 25 weeks, which is correct juga lah. So when the premature babies less than 24 weeks, they don't usually survive. Kan? Tapi bila baby tu is born, we know a 24-weeker, 25-weeker baby is totally different from a term baby. So if the marriage is just 6 months, kan, and the baby is born term from our assessment, kan, so we know already the baby is not, the baby is actually conceived out of wedlock. So this is the thing that I said to him, and it got more complicated regarding the discussion, which I think is very interesting as well. And I think the ulama, the Islamic scholars should discuss more with us, because I think there's so many issues. There's so many Islamic issues regarding this. Panjang lah. So we assess the cadre pulmonary assessment. We assess whether the baby is breathing well, the heart is beating well as well. So whether the child need any extra cardiopulmonary support. We make sure we assess the thermoregulation, because again, newborn babies, they cannot regulate their temperature really well, especially immediately after birth, because in mother's womb, the baby is warm. It's mother's temperature, 36.5 to 37.5. So it's very, very warm. And it's very, very warm. But then when the baby is born, our NICU, our delivery suite is quite cold. And then the baby is full with fluid. There are the fluid there. So you know when fluid evaporates, this reduces heat. You are losing heat when fluid evaporates. Fluid changes into vapor. This process, you lose heat by that process. So the baby, they have higher body surface, relatively higher body surface area. So they may lose heat much more. So that is why it's very important for us to assess the thermoregulation control. And we assess and support the blood sugar, because you know, babies, they get sugar from mother, but now they must depend on themselves to get sugar. So and then we observe the urine and meconium passage as well, because if the baby passes meconium before being born, so there is a risk for the meconium to be aspirated. Meconium, if it's aspirated, it gets into the lung, it may cause meconium aspiration syndrome. It can cause pulmonary hypertension, it can cause pulmonary hemorrhage. If the meconium is swallowed, the meconium can cause actually poor feeding. The meconium can cause feeding intolerance and so on and so forth. That is why it is quite important for us to assess the meconium passage. So ABGAS score, basically we assess respiration, crying, reflexes, whether the child is irritable, heart rate, we assess skin color and muscle tone. So we assess at several minutes, at 1 minute, at 5 minutes, at 10 minutes, and at least 1, 5, 10. That is the minimum. But sometimes we do need to assess up to 20 minutes. So 1, 5, 10, 15, 20, 25, and so on and so forth. Okay. So what do we assess for ABGAS score? ABGAS score is basically we assess this one. So appearance, the color and appearance of the baby, whether it's blue or pale, acrocyanosis, meaning blue at the peripheries, or the baby is completely pink. Heart rate, whether it's absent or is it slow or is it good. Reflex, the grimace of the baby, whether there's any response or just grimace, or the baby starts to cry and cough or sneeze and so on and so forth. How about the muscle tone? Whether the child is, ni bukan limp, ni LIMP, sorry, LIMP, limp, flat. And there is, or if there is some flexion or there's active motion, the respiration, whether breathing is absent, slow, irregular, or good and crying. So a good ABGAS score is 10. Zero ABGAS score means the baby, there's no signs of life lah in the baby. So what are the additional signs when you assess if the baby has respiratory distress? What are the signs? So first is the respiratory rate lah. Rate is more than 60. Less than 60 is still acceptable. So what are the other signs? Persistent cyanosis. The baby may be blue. Grunting. What is grunting? Grunting is basically you close your upper airway and you increase the intrathoracic pressure. You sound like macam you buang air besar kan. So that is grunting. So that is the grunting sound. So because when you increase intrathoracic pressure, you are opening up your airway. And then flaring of the nostril, kemang kecil hidung dia. Retraction, chest retraction, subcostal recession, intercostal recession, tracheal tug, and so on and so forth. Heart rate also, because you know the cardiopulmonary rate center is at your pons. So if you increase your respiratory rate, you also increase your heart rate. So that is why I think one good thing with us is that when we regulate our breathing rate, we also regulate our heart rate. That is why Islam teaches us to warattilil Qur'ana tartila. When you read Quran, you read with tartil. Warattilil Qur'ana tartila. Because you know when you read Quran, how you read Quran is the same as the breathing technique. If you have stress, for example, if you are anxious, among the technique that psychologists, psychiatrists use is the deep breathing technique. How you do it? So you breathe in with your nose, and then you breathe out slowly with your mouth. And then you breathe out slowly. So this is the deep breathing technique. With this deep breathing technique, you will regulate your respiratory rate and you will regulate your heart rate. When your heart rate goes down, you are much calmer. You tengok cerita Incredible Hulk kan? Dia ada jam dia check dia punya heart rate dia. Bila heart rate dia reaches more than 120, dia jadi Hulk, jadi hijau tu. Because when you reduce your heart rate, you are calmer, you are calm, you are more tranquil. So this is the same. When you read Quran with tartil, you are breathing with your nose, and then you are slowly breathing out with your mouth. So this will regulate your respiratory rate and it will regulate your heart rate as well. It increases venous return, it increases oxygenation, and helps you to reduce your heart rate. When your oxygen is higher, your heart rate, your respiratory rate will reduce as well. So this is what Islam teaches us. This is what the same as I always say, the Prophet told us, if we are angry, if you are mad, if you are stressed, if you are standing, we change to sitting. If you are sitting, you go and lie down. Why? Because when you sit, then you sit down, it will increase the venous return. When there's increased venous return, there's increased end diastolic volume. When you increase the end diastolic volume, your heart will pump, your cardiac output will increase, and to maintain the blood pressure, your heart rate will go down, because blood pressure is cardiac output times stroke times total peripheral resistance, and cardiac output equals to stroke volume times heart rate. So if you change your position, increase end-diastolic volume, it will increase the inotropic effect. Again, Starling law, increase venous return, increase end-diastolic volume, increase cardiac output through inotropic effect. So how the body will do to maintain blood pressure is by reducing the heart rate. So this is what your body will do. And so this is how, that's why Islam teaches us is very physiological. It's very physiological. It's the same. When you are angry, you go and take wudu. Islam teaches us. There's a hadith. The Prophet said, angry is like fire, so you cool it with water. It's true. Why? Because when you are in contact with water, and what does it do? Cold water, it causes vasoconstriction. And vasoconstriction, what does it do? It increases the total peripheral resistance. So how to maintain your blood pressure? So your body will reduce the heart rate. When you are cool, your heart rate goes down. When you are hot, when you are warm, your heart rate goes up. So that is why Islam teaches us. If you are angry, what you do is you go and take wudu, you go and take ablution. Okay, these are all physiological. How great what Islam has taught us. Okay, so what are the cause for respiratory distress? So respiratory system, so problems such as RDS, respiratory distress syndrome, which is a common finding in especially premature babies because of the surfactant insufficiency and surfactant insufficiency, as well as this is RDS is also called as hyaline membrane disease, and then transient tachypnea of newborn, TTN. Why? What happened in TTN is that the lung is full with fluid. That is why if you do, because while the baby is in the mother's womb, the lung is filled with fluid. And then because of the pressure from when the baby comes out through the vagina, there's compression to the chest, it pushes the fluid out and also pushes the fluid, because of pressure, it pushes the fluid into the lymphatics. So what happens is, especially in babies who are born with cesarean section, so they don't have that pressure because of vagina. They are not vagina, the pelvic too, they compression. But with cesarean section, the baby don't have this chest compression. So what happens is the fluid, it may remain there. It's not pushed out through the oral. It's not pushed out through the lymphatics. So that is why the baby may have lots of fluid in the lungs, and because of that fluid, what happens is the baby may have respiratory distress. If you do chest x-ray, you will see signs of fluid in there. You can see fluid in the fissure. You can see curly B lines, for example. And other non-pulmonary causes, such as cardiac causes, for whatever reason, ventricular septal defects or whatever septal defect, or complex cyanotic heart disease, for example, patent arteriosus, or those cardiac causes. It can be metabolic cause as well, hypoglycemia, hyperglycemia, both can cause respiratory distress, infection as well. Without any, we have one baby with sepsis, chest x-ray is totally clear, but the baby is tachypnic. So sometimes tachypnea, respiratory distress, may not be a sign of respiratory problem. It can be a systemic problem. So it can be problem with other system, because why? Our respiratory rate is not controlled by our lungs. Respiratory rate is controlled by our brain. So whatever that triggers, that fires up the brain, can cause us to be having tachypnea. So how do we lose to any surface that conducts heat? So this is how you lose heat. And then you may also lose heat by radiation. So you letak radiant warmer ke, ataupun you tak ada heat, so the heat dissipates through the air by radiation, or by convection kalau ada kipas, ada apa. So this is by convection, or by evaporation. So from the changes from fluid, from water, it changes into vapor. So this is evaporation. So this is how the baby can lose heat. So we must control this. So how we reduce? heat loss by conduction. So we put babies on mattresses lah, adalah kain dia kan, you put babies on mattresses, we wrap the baby using a warm punya cloth to cover the baby, kita pakaikan baju. So all this will reduce heat by conduction. We put the baby under radiant warmer, so the environmental temperature is warm rather than cold. So bila warm temperature, we reduce the heat loss by radiation. We put the baby inside a cloth, so reduce heat by convection. And we actually, rather than allowing the fluid to evaporate, what we do is kita keringkan baby tu, guna kain, guna towel, kita lap. So without the fluid, so there will be no evaporation. So we reduce the heat loss. So what's the normal temperature of baby? Is 36.5 to 37.5, and normal heart rate is up to 160. So 160 is still normal, it's still normal. And respiratory rate is 30 to 60, and blood pressure, usually we look at the mean arterial pressure is usually as the same as the gestational age, meaning a 25-weeker baby, the mean arterial pressure, the mean arterial blood pressure is 25. A 30-weeker baby, the mean arterial pressure will be 30. A term baby, the mean arterial pressure we expect to be 40. So blood pressure, mean arterial pressure is usually the same as the gestational age. And SpO2 we maintain more than 95. So so voids and stool maknanya dia kencing, dia DO. So we document from the moment of birth. Kalau sometimes baby dia pass urine at birth, dekat atas tempat kita resuscitate tu dia pass urine. So kalau ada, kita kena document. But sometimes baby tu ada banyak fluid dekat dia, kadang kita tak perasan kalau baby dah pass urine. So kita kena try and look for it. Okay, alright. Okay, so we expect baby to pass urine, we expect baby to open bowel. Usually should be the first 24 hours of life. If the baby does not open bowel, the baby does not pass urine after within the first 24 hours, then you need to look for the cause. There may be a problem. The baby may have H-prong disease. The baby may have meconium plug. The baby may have so many intestinal obstruction, malrotation. So look for the cause. If the baby does not open bowel, if the baby does not pass urine within the first 24 hours. And then when we should worry, when the baby does not void and does not pass open bowel the first 24 hours, when there's abdominal distension, we need to think of something like posterior uteral valve if the baby does not pass urine for the first 24 hours. So again, next is how do we assess for gestational age? I told you before, from the first assessment in the first 24 hours, we can know whether the baby is term, whether the baby is premature, and how premature is the baby. We know roughly, and I think that's very, it's almost up to the proper age usually. So how do we assess? We use with ballot score, ballot scoring. So this is the ballot scoring. You cannot see this very clearly, but what we do is we assess posture, for example. The one to the left is more premature, the one to the right is more mature. So a term baby, a premature baby, for example, the posture will be more like extended, and a more term baby will be more frog-like. So dia akan flex the limbs more, and more term baby, the angle will be less, will be more. Kan kalau premature baby, you tak boleh lipat banyak sangat, for example. And then arms scarf sign, heel to ear. You look at the skin, you look at lanugo. Lanugo ni rambut dekat belakang, for example. A more premature baby, there will be so many lanugo. More term baby, usually the back is bald, tak banyak bulu dekat belakang dia. We look at the plantar creases, for example. Plantar creases. So more premature baby, dia kurang crease. Sometimes dia flat saja, tak ada plantar crease langsung. Tapak kaki dia flat, chain je. But more term baby, dia ada banyak plantar crease. And then genital as well, female and male. So so skin, vernix, hair, ears, breast tissue. Premature baby, sometimes you tak boleh rasa dia punya breast bud dia. Resting posture, okay, I mentioned before, this is cracked skin. So cracked skin usually is a sign of term of more mature baby. More cracked skin, more is usually signs of maturity. Abundant lanugo, ni bulu-bulu kat belakang dia banyak. So kalau banyak lanugo biasa, the baby is more premature. And then ear, kita tengok ear dia. Ear recoil, pinna recoil. Kalau kita lipat telinga dia, a term baby dia akan macam kita punya pinna lah, kita punya telinga ni kan, pinna telinga kita ni, dia quite firm kan, bila kita buka dia akan terus balik ke tempat asal dia kan. Tapi kalau more premature baby, kalau you lipat dia tak, it doesn't get back to dia punya normal position. So this may be a sign of prematurity. Areola and increased lanugo, so areola dia more premature baby, dia akan more flat, you takkan rasa breast bud. So more term baby, you akan rasa breast bud, areola size and so on and so forth. So plantar crease, this is what I said. Kalau term baby, you akan see crease dia sampai the whole of the foot, of the sole. But more premature baby, dia akan clear saja, clear 1/3, 2/3, and then the whole crease. And then female genitalia wise, so normally the labia majora should be bigger than minora, but in a more premature baby, the minora is bigger, and then it will be the same size, and then baru majora akan bigger. So you see here, in a more premature baby, the minora is bigger. And in a more term baby, you can see the majora is big and the minora is covered. This is a male scrotum. You nampak dia punya crease dekat scrotum dia, kan? Tapi kalau more premature baby, scrotum dia akan flat, and then testis dia pun tak descended lagi. Resting posture, more premature baby, you nampak dia more extend posture dia. Lagi term, dia akan lagi banyak flex. Ni kaki dia pun, you can see the knee flex. In a very term baby, very mature baby, you nampak dia flex dekat dia punya shoulder, elbow, and dia punya hip, dia punya knee, you nampak dia dah flex. So this is a term punya posture. And then we assess the nervous system as well. What do we assess? We assess for the primitive reflexes. What are the primitive reflexes? Rooting reflex. Rooting reflex ni bila you letak benda, you stroke benda dekat pipi dia, dia akan cari. So this is the rooting reflex. Sucking reflex, if you put anything inside the baby's mouth, baby will start to suck. So these are primitive reflexes. You do Morose reflex. Morose reflex ni besok kita buat lah. Kita dropkan dia punya head sikit macam tu, dia arm dia akan extend dan dia akan recoil back. So this is a Morose reflex. You can do asymmetrical tonic neck reflex. Asymmetrical tonic neck reflex ni maknanya you facekan muka dia to one side, dia akan assume macam macam fencing punya posture. I have a picture. Nanti you akan nampak dia punya fencing punya posture. Stepping reflex ni bila you letak baby dekat surface dia punya dorsum of the foot, dia akan step. Macam ni tapak kaki dia kan. Ni kaki dia, bawah ni tapak kaki, ni atas dorsum kaki dia. Ni ada satu surface, you letak dekat bawah dia, dia akan step. And then ada lagi macam contohnya walking reflex ataupun dancing reflex. Palmar grasp, you letak benda dekat tangan dia, dia akan grasp. Palmar and also plantar grasp, foot grasp pun you akan nampak. So head lag, so newborn babies, they do have head lag. Sometimes they may increase a bit, but they usually have much. They have a lot of head lag. Morose reflex, dia akan buka dan dia akan coil balik. So this is what you can see. So tomorrow we'll try and do Morose reflex. Tonic neck reflex ni fencing posture. You pusingkan kepala dia pasang sebelah. The side yang pandang muka tu akan start to extend, kaki pun extend, and tangan dengan kaki yang di opposite side tu akan flex. So this is fencing punya posture. Next is dancing reflex or walking reflex. Kalau you pegang baby ventral suspension macam tu, you letak kaki di atas surface, dia akan gerak-gerak macam dancing, ataupun you akan nampak dia macam jalan. So kan ada video viral kan, baby tu jalan, kata miracle. No, it's reflex. So baby will walk. kalau kita pegang, kita letak tapak kaki dia dekat surface, dia akan buat walking reflex or dancing reflex. Sucking and rooting reflex, as I said before, you letak benda kat pipi dia, dia akan root, dia akan ada rooting reflex. Dan kita letak benda dalam mulut dia, dia akan ada sucking reflex. Palmar grasp, you letak benda kat tangan dia, dia akan grasp. Kat kaki pun sama, you letak dekat kaki, dia akan ada grasp, dia akan grasp macam tu. Plantar grasp. So, how do we assess the babies? Usually we go head to toe. We start from up, then we go down. So daripada atas, we look for the head circumference. Kan, head circumference, weight, and the length of the baby. You look for molding. Molding ni maknanya sometimes baby kat bawah, dekat mother perineum tu lama. So head shape dia akan ada molding sikit. Dia akan bentuk molding sikit. And then caput succedaneum is basically edema of the scalp. Cephal hematoma is basically bleeding under the skin. So you know, if you remember, the layers of your scalp kepala ni, dia ada layer dia. The first layer is the skin. Next is there's SCALP. So S is skin, C is connective tissue, A is your aponeurosis, L is your loose connective tissue, and P is your periosteum. Bawah periosteum is your bone. So, dia ada dua benda kat sini, cephal hematoma and also subaponeurotic hemorrhage. So, cephal hematoma is basically bleeding under the periosteum. Atas daripada skull bone, atas pada skull bone tu dia ada satu area, ada satu potential surface, lepas tu ada periosteum. So, periosteum covers the bone. So, cephal hematoma is bleeding below the periosteum. So, having said that, maknanya kalau bleeding dekat bawah periosteum, dia takkan go beyond the bone. So, maknanya kalau dia bleeding kat sini, for example, dia takkan cross midline. Dia takkan cross sutures. Sebab apa dia tak cross suture? Because cephal hematoma is bounded by the periosteum. Tapi you can lose blood lah. But subaponeurotic hemorrhage is bleeding below the aponeurosis. Aponeurosis ataupun satu lagi nama dia is galeal. So subgaleal hemorrhage is equal to subaponeurotic hemorrhage. Maknanya the aponeurosis, the subaponeurotic punya area is area that is continuous throughout your body. Daripada atas sampai ke bawah dia continuous. It's a potential surface. Kalau you bleeding daripada situ, especially it is a venous bleeding. Contohnya baby keluar nak deliver tu, pakai vacuum pressure kuat, sometimes there may be because shearing of the vein, koyak because of pressure. Kan, so vein tu koyak. So you know vein is not as muscular as artery. So bila dia not as muscular as artery, dia nak bleeding to stop is a bit difficult. So problem dia adalah you can lose a lot of blood. You can lose your whole blood into the subaponeurosis. So subaponeurotic hemorrhage is a major cause lah. So look for subaponeurosis. How do you differentiate between cephal hematoma and subaponeurosis? So caput succedaneum is actually edema. Cephal hematoma and subaponeurotic hemorrhage are bleeding. So dia fluid. So bila dia fluid, bila dia bengkak, dia swollen, you can see the bogginess. Dia boggy. Kan? You can see there's bogginess. And then dia tender sebab dia increase the surface punya pressure. So there'll be tender. Cephal hematoma does not cross the midline. It does not cross the suture. But subaponeurotic hemorrhage, subgaleal hemorrhage, it can bleeding, it can cross anywhere, it can go to your whole body. And anterior fontanelle usually close between 12 to 18 months, and posterior fontanelle usually close by the end of the second month. Molding you nampak ni. Ni because of the vacuum you can see molding. Cephal hematoma bleeding kat situ, nampak dia bonjol sikit kat situ. If you rasa dia fluctuant, tender. So caput succedaneum is basically just edema. It's just edema. But cephal hematoma ni dia bleeding above the periosteum. This is tapi dia bound by the periosteum, so dia takkan cross the midline. Tapi kalau subaponeurotic hemorrhage, you can bleed whenever and wherever. So you look at the eyes as well. Eye placement dia macam mana, size eyes dia macam mana. Ada slanting of eyes tak? Kan? Ada epicanthal fold tak? Red reflex present tak? Sometimes absence of red reflex is a sign of congenital infection, torches, toxoplasma, rubella, CMV, herpes. So it can be a sign of retinoblastoma, for example. Newborn babies can get retinoblastoma. Is there any, if you tap, glabella tap, is there any blinks, glabella tap, any discharges, pupillary reaction dia macam mana? Does the baby follows midline tak? Kan? So you look at the eyes. You check the hearing response. Kalau sudden sound, clap the hand, baby akan tunjuk moro. Kan? And placement of the ears. Ada low set ears tak? Ada ear ke tak ada ear? Sometimes, for example, babies with golden hair syndrome, dia ada asymmetry. Sebelah telinga ada, sebelah telinga tak ada. Dia ada right ear skin tag tak? Right ear skin tag sometimes is associated with renal abnormalities. For example, macam horseshoe kidney, for example, kan? So, apa finding? Kadang dia ada nampak, you can see the pinna, tapi tak ada lubang. There's no external auditory meatus. Kan? So, you look at the ears, whether there's any proper external auditory meatus tak? Telinga dia nampak normal ke tak? And babies, it should be universal hearing assessment, which we are not able to do yet in SUSMED, but I'm hoping that we can do later on. We should do. So it should be a universal. All newborn babies should receive a hearing assessment. And then respiratory, then we go down further, we look at the respiratory and cardiovascular. We look at whether there's any cardiorespiratory issues, whether the breathing is okay, whether there's any murmur, how's the heart rate, whether the femoral pulses are present. Sometimes kalau tak ada femoral pulse, you need to think, is it coarctation of aorta, and so on and so forth. Okay, and then, so again, children, newborn babies, they are obligate nasal breathers. They don't know how to breathe by their mouth. So if you block the nose, they cannot breathe. They are obligate nasal breather. They can only breathe with their nose. You assess whether there's any subcostal recession, intercostal recession, nasal flaring, and then femoral pulses, brachial pulses. You need to feel, look for coarctation of aorta. And then musculoskeletal, again, look for symmetry, because you have two sets of, there should be symmetry, right and left. And you look for symmetry. You look for whether the child has enough fingers or there's any polydactyly, syndactyly. So you need to look for all those things, because I've seen people missing a baby with polydactyly. Siapa boleh bagi tahu seorang very glamour punya actor yang ada polydactyly?
Hendrik Roshan.
Hrithik Roshan. So Hrithik Roshan ada polydactyly kan. Kenapa tak buat pun tak tahu. And then the clavicles, are the clavicles okay or not? Movement of the arms, you assess the DDH, whether the hips is clicky or not. So how do you assess clicky hips? You do Otolani and Balo test. Otolani is you put the Otolani and Balo. So and then you assess for club foot, CTEV, congenital talipes equinox virus, or the opposite, which is so you assess, and then you look for the back, look for curvatures of the back, any cysts or any sacral dimples, and so on and so forth. So you do Otolani and Balo. So Otolani, basically you open, you get the you get the hip to go out from the socket, and Balo, basically you push back the hip into the joint. And then you look for skin folds. You assess the genitourinary. So whether the child is male or female. If the baby is male, you need to assess the testis. Where is the testis? If you cannot feel the testis in the sac, you need to look for the testis. Whether the testis is just at the base of the scrotum, or is it deeper? If it is in the inguinal region. If you cannot feel the testis, you need to assess, you need to get ultrasound, because we need to find if the testis is intra-abdominal, there is a risk for teratogenic change. So that's why we do need to find if there is ambiguous genitalia, then that is a neonatal emergency. So you need to do many assessment, and there's so many issues for you to settle. So make sure how is the genital? Is there hypospadias, for example, any fistulas, and so on and so forth. So do need to assess. Sometimes pseudo menstruation ni maknanya sometimes bila baby tu born, you nampak blood dekat from the vagina. That can be normal. It's not menstruating. It's just because of hormones from the mother. So you may see blood to the vagina as well, which is normal. So GI, you assess passage of meconium. Kalau baby tak pass meconium, could it be meconium plug? Could it be abdominal intestinal obstruction? Could it be Hirschsprung disease? You look for patency of anus, whether the anus is patent. I have seen people missing anal imperforated anus. I've seen people missing imperforated anus. The baby is passing meconium but passing through the vagina because there's a rectovaginal fistula, but there's no anus. So you need to correct that. Without anus, the baby cannot pass meconium. So this is the thing. So the abdomen should be soft, it should be non-tender, it should be round, but should not be distended. Bowel sound should be present, and umbilical cord, you need to assess whether the umbilical cord is normal with 2 artery and 1 vein or not. So you check whether there's echocyanosis, you check whether there's any discomation, you look for Epstein pearls, you assess whether there's any erythema toxicum, you assess the color of the baby, whether there's any milia or not, Mongolian spot, look for port wine stains as well. Okay, then you assess whether the child is jaundice or not. What is jaundice? Jaundice is the yellow discoloration of the skin. And this is common because babies, they have HbF, and HbF has shorter lifespan as compared to the normal RBC. And I think we should discuss about physiological, what is physiological jaundice, what is pathological jaundice. And this is the nomogram for the phototherapy. I think we've discussed before about phototherapy, exchange transfusion also we've discussed. And if you look at the eye, this is subconjunctival hemorrhage. Subconjunctival hemorrhage, which is normal as well. What is this? Sometimes the baby may have gynecomastia, which is normal as well. This is because of apa? This is because of hormones from mother. And then Mongolian spots. This is milia. Strawberry hemangioma. This is strawberry hemangioma. CTEV. And okay, all right. So these are the examinations that you can do lah. All right. So we look for other congenital abnormalities. Is there any signs of congenital heart disease? DDH, where the hips are clicky. It is a dislocatable hip. Whether there's any talipes, signs of Down syndrome, cleft lip and cleft palate, so you need to assess. And any urogenital abnormalities, spina bifida, sacral agenesis, anencephaly, and so on and so forth. Okay, all right. Any question? Kita semua dah ada urut cetong dah. Any question? Clear? Simple kan? So examination, you start just to give you an idea. So we look from the head, look for any type of abnormality, and basically you are assessing normality because you expect 80% of the babies that you examine will be normal babies. So this is what you do. It should be a head to toe examination. Okay, all right. Anything? We'll discuss more on the practical session tomorrow and day after, where you will actually practice on some of the babies how to do newborn examination. Okay, all right. Okay, let's end our session with tasbih. Ada soalan? Yes. Tak dengar soalan.
Nak tanya. Ya, macam mana nak hari tu ada macam pergi
First
sebab hari tu ada pergi NICU and one of the baby ada Dr. Alwi cakap lah ada hyperinsulinemic phases, tapi macam tak boleh nak identify what's the apa yang dia punya dysmorphic features tu.
Tak berapa clear soalan tu. Is it my connection or your connection?
My connection kot.
Yeah. So I think you are asking about hyperinsulinemic phases. Okay, dia macam ni. So basically the assessment is actually assessment of a infant of diabetic mother. So infant of diabetic mother dia ada banyak problem dia. It's a head to toe punya problem. Again, if you are looking at infant of a diabetic mother, problem dia it can be it can be the early pregnancy or later in pregnancy. So what is the problem with infant of diabetic mother? So the first trimester, the problem is unopposed hyperglycemia because sugar crosses the placenta into the baby. Sugar from mother crosses the placenta into the baby. But insulin is a big molecule. Insulin does not cross into the baby. So baby needs to produce its own insulin. Baby needs to produce its own insulin. And baby's pancreas will only start to function around 8 to 12 weeks. So before 8 weeks, there is unopposed hyperglycemia. Sugar crosses from mother into baby, but baby cannot produce insulin. So there is unopposed hyperglycemia. And this unopposed hyperglycemia is teratogenic. This is what causes congenital heart disease. This is what causes sacral agenesis, spina bifida in infant of diabetic mothers. Okay, that's the first part. Next one, when the baby's pancreas starts to produce insulin, so this is why infant of diabetic mother with underlying diabetes, they are more at risk. So people don't usually control. Sebab itu, a mother with diabetes, the mother should control blood sugar 3 months before conception. So 3 months before trying to get pregnant, mother should already control the blood sugar. Okay, because you know pregnancy is a diabetogenic state. Anyone pun, the moment they're pregnant because of all the hormones, it is a diabetogenic state. Yeah, so that's why you need to control early on. And most women, they only know they're pregnant after 6 to 8 weeks. Before that, they don't know they're pregnant. They only know when the pancreas of the baby starts to function. Before that, they don't know. And that's the problem. Unless it's yang bukan spontaneous punya conception, IUI baby ke IVF baby ke, itu kita memang plan dan kita check. That's something else. But usually they don't know. So there's unopposed hyperglycemia which is teratogenic, which is dangerous. So lepas tu bila baby dah start produce insulin, so the baby has been used to producing high levels of insulin, especially kalau sugar mother tak control. Even if the mother sugar is controlled, there will be periods where the sugar level jumps up. So baby is used to producing high levels of insulin. You know, insulin is insulin-like growth factor. So insulin functions like growth factor. It causes overgrowth of certain organs. It causes overgrowth of the heart, especially the interventricular septum and the cardiac muscles. So it causes hypertrophic obstructive cardiomyopathy. The interventricular septum is big because of the insulin-like growth factor. It causes the placenta to be big. But when the placenta is big, sometimes there may be placenta insufficiency. Then the baby can be small. But insulin-like growth factor also causes the baby size to be big. So baby jadi macrosomic. And because of all this as well, baby akan jadi macam mana? Baby akan jadi because of placental insufficiency ataupun because baby tu besar, kan, what happens is there will be reduced perfusion to the baby, relative hypoxia. Relative hypoxia, how the body responds to relative hypoxia? Body responds by producing more RBCs. So bila body produce more RBC, the baby will be polycythemic, plethoric. So RBC dia akan tinggi, HB dia akan high hematocrit, thrombotic punya condition. You can cause thrombosis anywhere. It can cause thrombosis in the brain, causing stroke. It can thrombose in the heart, causing myocardial infarction. It can thrombose in the bowel, causing necrotizing enterocolitis. So it can thrombose anywhere. Kan? So, and then the baby itu banyak vernix. Vernix tu yang putih-putih cover tu. And then the baby will have apa lagi? Dia punya telinga dia hairy ears. So hairy ears ni usually is Y-linked. It's Y-linked. Normally it's Y-linked. Sebab tu certain orang lelaki tu dia ada nampak telinga dia banyak bulu-bulu. That is Y-linked. Kan? Tapi juga in infant of diabetic mothers, because of the hormone and things, you may see hairy ears as well. Those are the things, for example lah. Okay. Lagi. Soalan lain? Okay lah, cukup lah already 1 hour. I think that's it. Online teaching is tiring. So we'll see you in the afternoon. So someone please get the things. I've already asked my MO to make to prepare the things. At 2:30, please come to NICU. Look for Dr. Farhani. Look for Dr. Farhani. And when you get to Dr. Farhani, please call me. Please call me first, just to make sure that we have everything adequate. Okay. All right. That's it. Let's end our session with tasbih kafarah and surah Al-As. Okay, Assalamualaikum.
Thank you, Doctor.
Mas Doktor.
Assalamualaikum.